Hi, I'm Ken Howard, and welcome to the Gay Therapy LA podcast. Today we are celebrating 50 episodes. Thank you to all the listeners out there around the world, and just really appreciate you listening to this episode or any of the episodes, since there are now 50 of them with more to come. Appreciate the ratings, the reviews, questions, and getting to meet some of you. So thank you for these first 50 episodes. If you have suggestions for more, we'll have more coming. And it is my pleasure to do this, and I hope you find them helpful. Now, episode 50, Gay Men's Sexuality, 3 types of erectile dysfunction and their interventions. Just a word of warning, this is an adult clinical discussion of sex therapy topics provided by me as a licensed clinical social worker in California and trained sex therapist. It is not restricted adult content, nor is it literary erotica or pornography, but listener discretion is advised if you're sensitive to frank discussions of sexual health topics. So, in my long 28 years career as a specialist in therapy for gay men, and my relatively recent emphasis on sex therapy for gay men, perhaps the most common complaint I hear from my clients is about erectile dysfunction, problems getting hard, all of that, which is really just the ability for a cisgender man to get hard and stay that way enough to enjoy a full cycle of either oral or anal intercourse. And of course, this would include vaginal sex for straight guys, but the focus and specialization in my practice, since its inception for myself as a founder and for my associate clinicians at Gay Therapy LA, has been on gay men. And so that's where our focus is today. While it's important to remember that, some studies have found that gay men don't like anal intercourse, some of them. And that's fine for a certain percentage of gay men who just kind of never go there. But another whole proportion do, and to be able to engage in the top role and the related sexual pleasures therein for both partners can be a lot of fun. So that's why we want to troubleshoot the things that get in the way of that kind of enjoyment. So there are 3 phases. Let's talk about those. Erectile dysfunction can be thought of in 3 phases. 1, getting erect upon arousal or stimulation. 2, getting erect enough to penetrate. And 3, staying erect through intercourse. So recently, in the case of, let's call him Paul, names and other details are changed for confidentiality reasons, we explored in sessions how erectile dysfunction in general is not as precise a discussion as we might need. For Paul, getting hard or the initial erection was not a problem for him. It was staying hard enough to penetrate his partner and to sustain that erection long enough to complete anal intercourse, ideally to mutual orgasm. In working with Paul, our exploration of what was going on brought to mind the 3 phases, or these points in the process, where erectile dysfunction can occur. Medical doctors and other types of medical providers might discuss these phases as well, such as an endocrinologist or a urologist. And sex therapists often collaborate closely on client cases with the client's MD because erectile dysfunction can have both the medical, blood flow, hormonal balancing, free and total testosterone levels, estradiol or estrogen levels, blood circulation, and all of these things. It can have those components as well as a psychological component. So in a previous episode, I discussed erectile dysfunction and its related cognitive causes and cures, as well as separate podcasts on gay men and the fear of topping or the fear of bottoming. So this kind of is a part of that series, and you may be interested in hearing those previous episodes. Again, erectile dysfunction and its cognitive causes and cures was one, and then also gay men and the fear of topping or gay men and the fear of bottoming. Those were 2 different episodes. Let's look at assessment of the ED situation. So if you're experiencing erectile dysfunction, try to break it down into a more precise self-understanding of what's going on. Do you have problems in the early stages, such as feeling sufficiently horny with sex drive and desire? Do you have any initial erective response on arousal? Or is your penis flaccid even if you have some sexual desire, but it doesn't respond to visual, situational, mental, or physical stimuli? Or is it more that you can get partially erect, but the erection is short-lived and not sufficiently sturdy enough to penetrate the mild resistance posed by the closed sphincter muscle of your partner? Or can you penetrate and get inside, but not sustain the erection long enough for you or for your bottom partner to achieve orgasm for however reasonably, keyword reasonably, a time that you're enjoying intercourse together? In the case of Paul, his complaint was that using a common ED medication, Cialis, also known as tadalafil, helped him enough for him to have that initial erection, but he psyched himself out on trying to penetrate his relatively new boyfriend, Lorenzo. A general practitioner, MD, had prescribed Paul the Cialis. When we explored what he meant by psyched himself out, he explained how he gets in his head about whether he can sustain his erection long enough to satisfy Lorenzo, who had a long reported history of being an enthusiastic bottom. He also thought about how, in his last, very long relationship, Paul and his previous partner generally avoided penetrative anal sex and had opted for oral play for nearly all of their life together. He and his previous partner had been perfectly satisfied with oral sex, cuddling, mutual masturbation, kissing, and massage and touch. However, Paul felt pressure verbally from Lorenzo, who liked to really get it on and considered Paul's sexual repertoire underdeveloped, which left Paul feeling insulted by his new boyfriend when he and his previous partner didn't have anal sex and never missed it. So let's look at the cognitive versus medical causes of ED. This goes back to what I discussed in the previous episode about cognitive aspects of ED. Perhaps Paul was having trouble penetrating Lorenzo because he had an unconscious resentment that Lorenzo was making him do a sex act that he just wasn't that into. Or maybe Paul had leftover feelings for his previous partner, and he was ambivalent about the new relationship with Lorenzo, who could be bossy. We've all heard of the bossy bottom syndrome, which could make a top partner feel demanded upon and creates performance anxiety in the top. Maybe, getting older, Paul had doubts about many aspects of feeling active and vibrant. We all know that ageism, especially in the gay community, can make older gay men feel not only physically impotent, but socially and professionally devalued or irrelevant in a generally youth-obsessed gay male culture. And maybe Paul was suffering from the self-doubt of a diminished self-concept due to internalized ageism. Or perhaps it was just medical. Problems such as a side effect of blood pressure medications, HIV antiretroviral drugs, or hormonal imbalance, work-life stress, a recent trauma, a history of incest, sexual abuse, or sexual assault, or even a lack of sleep have all been known to diminish desire and sex drive. One concern I had was that Paul being prescribed Cialis by his general practitioner, MD, might not fully address the problem sufficiently regarding the dosing of the drug or perhaps even the type of drug used. Maybe another oral ED drug like Viagra or Levitra would help Paul have a better response with harder and more robust or enduring erections. Even more so, Paul's relationship with his medical provider, and that could be an MD or DO or a physician's assistant or a nurse practitioner, all of whom are legally allowed to prescribe medications, left out the options that another type of provider, such as an MD endocrinologist who specializes in men's health issues, including sexual dysfunction, such as those where I'm a patient of defymedical.com, DEFY medical.com. DefyMedical.com is a specialty medical practice in Florida that provides telehealth to I think all 50 states. I'm not sure if telehealth is legal in all 50, but anyway, DefyMedical.com is one of a number of resources that specializes in troubleshooting sexual issues, especially for men. And that type of provider might discuss this and some of the options, such as the injectable medication options. Combinations of stronger ED compounds that are known as trimix or quadmix, which are 3 or 4 drug agents that are compounded together by a specialty compounding pharmacy. And then the patient uses a very small insulin-style 1 cc needle to inject the side of their penis with very, very small amounts of the liquid drug, and then massages the shaft to distribute the drug, resulting in a strong erection. Sometimes too strong. That can lead to a painful erection or even priapism, which is a dangerous condition of enduring, like over 3 hours, erection that needs an antidote ejection with another type of drug, or possibly an emergency room intervention. So Paul reported that he and his GP/MD never discussed the injectable drug options. And I often hear from clients that not all possible medical or pharmaceutical approaches are discussed, which is why specialty providers are often needed to troubleshoot these medical issues in greater detail. But in session, I educated Paul on the availability of the injectable medications, but the scope of practice for me as a licensed clinical social worker and sex therapist couldn't ethically go too far into a medical issue without deferring to a licensed medical provider. There's just a boundary there about the scope of practice of what each professional can do. So I encourage Paul to consider having a consult with his medical provider to discuss his eligibility to be assessed for the use of an injectable agent versus the oral drugs, and that's called psychoeducation. That's when a psychotherapist educates a client on various resources and options in a way that has a psychological component, such as trying to reduce the client's anxiety or depression by discussing resources that might give the client new behaviors to try, or new ways of thinking about an issue, or new external resources to access that might assuage anxiety or give hope to combat the helplessness of depression. And this can be just telling a client about how certain things work in nature with a somewhat limited kind of medical bent to it. It can be referring them out to a website or a book that has more information. And that kind of education and that kind of linkage and brokerage, it's called, to external resources can be a part of the work in therapy. It's very behavioral based. Let's talk a bit about self-talk in erectile dysfunction. I also explored Paul's cognitive self-talk when he penetrates Lorenzo. What were his negative self-statements that we say in cognitive therapy that he told himself in the heated moment of sex? Did he question his ability? Did he question the purpose of intercourse? Did he express to himself self-doubts about being enough in sexual performance? Was he afraid of negative evaluation by Lorenzo, like he would get a bad grade at being a top? While trying a new medication like Trimix could certainly help erectile performance, so could identifying and then rewriting in Paul's head the negative self-statements that were psyching him out in the moment. Let's talk about sensate focus. Another component used in erectile dysfunction when someone is in their head about it is to do something that sex therapists call sensate focus, which is focusing on the sensations you feel and not just focusing on your partner. Issues of desire and good sex can involve a certain amount of selfishness. Sure, you want to please your partner, but ironically, you might please him by focusing on your own pleasure and assuming a dominant top role. You're indulging in the pleasant sensations of taking your bottom partner as he deserves to be taken. Legendary couples therapist Esther Perel, the licensed marriage and family therapist, she's from Belgium, but she practices in New York City, says that good sex is not politically correct and that equality belongs in every other room of the house except the bedroom. It's okay to be a selfish, dominant top who treats your bottom like a piece of meat within reason. Sometimes it is this mindset of focusing on your own pleasure, not your own anxious thoughts, that helps you to be a better lover, with stronger and more effective erections that literally hit the spot, the prostate, of your bottom. Another component of sensate focus is to get out of your own head and focusing on the other person, your sexual partner, to the extent that your own senses are stimulated. What does his hair look like in the dim light of a candlelit room? What is the gleam of the light on his slightly sweaty pectoral muscles? How cute is his smile when you see him grin as he talks dirty to you? What happens for you when you say something provocative? How does the look in his eye talk dirty to you without saying a word? What does he smell like when his natural musk combines with his favorite cologne he wore on that night on his date with you? How aesthetically beautiful is his chest hair pattern? How do your hands feel when you hold his ankles up and look into his eyes? What do his kisses taste like? When you focus on what you see, hear, smell, taste, and touch on your partner and how these senses affect you, sometimes the penis has a mind of its own in response to attraction and desire for this beautiful guy that you're about to plow like the South 40 cornfield. These kinds of sensate focus exercises can help at every stage of the desired erectile functioning. Early on, during foreplay, where Esther Perel's foreplay begins after your most recent orgasm. This is part of ideas from her book, Mating in Captivity, Unlocking Erotic Intelligence, or one of her brilliant TED Talks online. Check those out if you don't know Esther Perel's work. It's really fascinating, all of it. And this sensate focus can help you during that foreplay, or upon penetration, or during intercourse, in all three phases. Positive self-statements that underscore your role as a top can also help the five senses. I can do this. I'm going to nail this guy. This guy is mine. I'm the lucky one here. Or you're in for a treat, dude. All of these confident, assertive statements that help you to have the confidence to romantically or erotically take your partner in the way that he wants to be taken. So use your imagination. Think of what tops in porn say out loud, and you can say something similar, or just think it in your self-talk to turn yourself on in the process. Let's look at putting this together. While a better goodness of fit between patient and prescription drug can be used in the various stages of erectile function, such as the oral agents versus the injectable ones, so too can the cognitive self-interventions like sensate focus, focusing on your partner sensorially, the five senses, and your own positive self-talk. Being a better lover is always a dance between the strictly physical and medical aspects and the psychological, emotional, interpersonal, domestic, cultural, and social aspects of two or more people engaged in sexual play. Becoming a better lover is a process, not an event, but it is punctuated by an ongoing series of sexual events, either alone or with a partner. It's also not done in isolation. The influences of your partner, your medical provider, a sex therapist or coach, and certainly your relationship with your own self and your own head are a gradual skill-building journey that tends to get better with time and experience, and a certain indulgent abandon when so much of life demands us so much accountability and responsibility and self-denial. We have to be the good employee. We have to be the good neighbor, or the good parent, or the good son, or the good provider. Gay men don't get many messages growing up in our usually heterosexual families of origin that responding to our own desire is validated or valuable. It is up to us to balance our many responsibilities as good citizens with also allowing ourselves the indulgence of sexual abandon with consenting, non-exploited partners that heterosexuals, especially men, have been taught for a lifetime to take for granted. Gay men's sexual self-empowerment means reclaiming our right to our own pleasure on an equal plane. So if you'd like some customized help on some of these issues, consider having help from a sex therapist or coach. My associates and I at gaytherapyla.com are here to help. We're currently providing online or phone sessions because of the COVID-19 stay-at-home guidelines. So you can email me, Ken at gaytherapyla.com, or you can call and text me, 310-339-5778 in the United States. I think you have to put an 01 if you're outside the United States. Area code 310-339-5778, and you can get more information or book an appointment to discuss some of the things that might be valuable to you, not only about sex therapy, but just therapy in general, or coaching. It's coaching if we're working outside of California, where I'm licensed. So we would be happy to help on this or any other topics that you think you might find helpful. We are here for you. Thanks, and I'll see you next time.